Thanks to everyone for joining this webinar. So we are currently experiencing a global surge of type 2 diabetes, and the drug development in this area has mainly focused on improving blood glucose control. But despite the development of GLP-1 receptor agonists, and perhaps more importantly, SGLT2 inhibitors, which have shown to be nephroprotective beyond the blood glucose lowering effects, patients with type 2 diabetes are still at high risk of developing diabetic kidney disease. And thus today, diabetes is actually the single most important cause of CKD, chronic kidney disease, worldwide. So there is still a need for target discovery and drug development within this disease area. And in order to support that research, preclinical models of diabetic kidney disease with improved translatability are needed. Before I jump into discussing how we can actually improve the current rodent models of diabetic kidney disease, I think we should have a look at how the disease develops and evolves in man. So what you see here is two parameters that we actually measure in the clinic. So the blue line or the blue curve is representing a kidney function measured as a glomerular filtration rate. And as you can see here, with the years of diabetic kidney disease or diabetes, GFR or kidney function actually remains quite stable for many years until it starts to decline. The other parameter that we actually measure in patients with diabetic kidney disease is albuminuria. That is albumin that leaks into the urine. And what you can see here is that albuminuria actually steadily increases over time. So these are two clinical parameters that we measure in the patients to monitor progression of diabetic kidney disease, but we can also look into the kidney, and in some cases we actually have biopsies from patients with kidney disease to see how that looks. So in the very early stages of the disease, we have only very mild features such as hypertrophy, the kidney becomes larger, and also the glomeruli becomes larger. So this is a kidney glomerulus, and what you can see here is that it looks fairly normal. And how can we see that? Well, it has really nicely small open capillary loops, and then we have very little pink material inside, so there's very little mesangial expansion. Moving on to the later stages, so still in the early phase of diabetic kidney disease, we begin to see features like this pink material, this mesangial expansion. This is very characteristic for the more early changes in diabetic kidney disease in men. And then at later stages, we start to see glomeruli that are severely affected by glomerulosclerosis, and also these, what we call nodular glomerulosclerosis, appear. We can also see tubal interstitial fibrosis with thickening of the basement membrane, and also buildup of fibrosis between in the interstitium. Finally, in some patients, but not all, the patient actually progressed to what we call end-stage kidney disease. Here, the kidney basically fails, and the patient is in need of kidney replacement therapy, that being either dialysis or kidney transplant. But not all patients end up here, and I just want to stress this because I think it's really important to realize that the main risk for patients with diabetic kidney disease is actually they also often have hypertension, and they also have a high risk of cardiovascular disease and death from that. So this is what diabetic kidney disease looked like in man. Now let's have a look at what it looks like in our rodent models of kidney disease. Well, in rodent models, or actually in many of our rodent models, we see only these very early stages of diabetic kidney disease. We see only mild glomerular changes, so only enlargement of the glomeruli and expansion of the mesangium. We see only mild albuminuria, so that's microalbuminuria, and we also see a very normal GFR. It might also be elevated, so it might be hyperfiltration, but it's very rarely that we see progression towards kidney failure. And this is actually our challenge. So we would like to have models that also replicates the more advanced stages of the disease, and perhaps even go into end-stage kidney disease, because we know that they have better translatability. So here are the two key questions that I'm going to try to address in this talk. First of all, I'm going to try to give you an example of how we can overcome this challenge with the translatability of our, especially mouse models of diabetic kidney disease. And secondly, once we've established a good model, I'm going to kind of give an example of how we can actually confirm that translatability in these models. So first of all, let's have a look at what the mouse models look like and how we can kind of improve them. So rodent models of diabetic kidney disease can be categorized in many ways, for example, according to whether they have type 1 or type 2 diabetes. We can also categorize them, as we've done here, as to whether they replicate the features of early stage diabetic kidney disease or later stages of diabetic kidney disease. Here are some examples of rodent models of early stage diabetic kidney disease. I think some of these are familiar to you. Among others are the STZ rat and mouse model of type 1 diabetes and the SDF and the DBDB mouse model of type 2 diabetes. I think a common thing here is that these are easy to access. They are not really very complicated to run in a laboratory, but they do only show features of mild disease. I think they can be good, in especially the STZ models, if you have a transgene model that you want to check out how the transgene actually affects the progression of diabetic kidney disease, then this might be the way to go. Models that replicate later stages of diabetic kidney disease, I've brought some examples here, and I think what I want you to notice is that these models do not only depend on the animals being diabetic, but also require other modulators to really advance the disease and make it progress into these later stages. So an example of this is for example, a model where we knock out the ENOS gene and then put that on a background either in an STZ model or a DBDB mouse model. So how is the translatability between all of these models? And I've only shown you a small selection of models here. If in general, if we compare results from clinical trials in humans with data from drug testing in animals where we have tested the same drug, we actually see that animal models that have these, that replicates the later stages of the disease, actually have better reproduce the responses to that drug and better resembles what we see in men. So based on this, I'll now give you an example of how we can improve the translatability based on the DBDB mouse model of type 2 diabetes, and how we can improve that using various modulators of disease. So the modulators that I'm going to address here are mouse strain, and thus the genetic background of the mice. I'm going to talk a bit about how we can reduce the nephron mass to put stress on the remaining kidney mass. And then finally, I'm also going to talk about how we can induce hypertension as a third modulator of kidney injury. So I think it's fairly commonly known that the mouse strain affects the susceptibility to not only diabetic kidney disease but kidney injury overall. So here is an example from the DBDB mouse model. So this is a mouse model of type 2 diabetes, mice that are hyperphagic and obese. They develop insulin resistance and diabetes, and they also show some features of early diabetic kidney disease. The degree of kidney injury in this model actually depends on the strain. I'm going to show you some data here from 3 different background strains on which we have applied the DBDB genotype. And the data here I'm going to show you are albuminuria data. And I'm going to show you data where I compare the levels of albuminuria in the DBDB mouse, compare those to a healthy age-matched control. So if we have the DBDB genotype on the black 6 background, we see a very modest increase in albuminuria across time. So only 4- to 5-fold increase, and that's really not very impressive and nothing like what we see in humans. If we look at the BLKS strain instead, so the BLKS strain I think is the most often used strain to study not only diabetes but also diabetic kidney disease. And when we look at that, we see an increase in albuminuria towards 20-fold between the diabetic and the healthy controls. So this also looks a bit more impressive, but what you also need to notice here is that we don't see any progression over time. We see progression in man, and we would really like a model that also shows progression over time. So what happens then if we use the DBA2J background? So in other models of kidney disease, DBA2J is known to be very susceptible to kidney injury. And this is actually also the case in this diabetic model. So here you see that the albuminuria actually increases 60-fold in the diabetic mice compared to the healthy controls. So this is actually more impressive and seem to show that this model is really prone to kidney disease, both in a setting of type 2 diabetes, but also in other settings. Unfortunately, the availability of the DBA2J DBDB mouse model is really not very good. So the rest of the data that I'm going to show to you today are from the BLKS background, and this is what we've built our model on. So moving on to a second modulator, which is a reduction of nephron mass by uninephrectomy. So uninephrectomy, or removal of one kidney in the mice, is a common tool that is used across not only metabolic models, but also other models of kidney disease. So in this and in other slides, I'm going to show again data on urine albumin to creatinine ratio, or albuminuria, as a marker of kidney injury. And in this particular study, we used a healthy control group, a non-diabetic healthy controls with 2 kidneys as the baseline, and these have very low levels of albuminuria, around 100. Then if we look at the diabetic DBDB mice, but again still with 2 kidneys, we see increases of albuminuria towards 2,000. And this is kind of very reproducible and what we've seen in similar studies. And then finally, if we add this uninephrectomy to try to accelerate the disease and increase albuminuria, we see a small increase in albuminuria, but nothing really stunning. And this basically tells us that we need a third modulator, or perhaps even more, to really push the disease further in this model. So that third modulator is actually hypertension. And again, this is also a modulator that has been used in other settings, and you can actually induce hypertension in various ways in mice and rat. Here we have chosen to use an adeno-associated virus that expresses renin, and that virus is actually inserted in the it's given in the system, and then it inserts into the liver, and from there it expresses high levels of renin into the system and thereby activates the rest system to induce hypertension. So in this study, we used only DBDB mice, so only diabetic mice, and they were all uninephrectomized. And then we wanted to see if we could use this vector to induce hypertension. And how does that look? Well, in mice that were injected with a control vector, we saw that they were normotensive, meaning that they had normal blood pressure at around 125. Injection with this renin associated or adeno-associated virus expressing renin, we saw that we could dose-dependently increase the blood pressure in these animals. So this is a really nice dose-dependent increase in blood pressure towards 200 in the dose that received the highest in the group that receives the highest dose of the vector. That's really nice. We can now control blood pressure in these mice, but how does that affect the kidney phenotype? Well, again, let's have a look in the same study with the same groups. Let's have a look at albuminuria again as a marker of kidney injury. So again, the normal group, so these are DBDB UNx mice. Diabetic mice that are normotensive, they have albuminuria around 1,500 to 2,000, as I also showed in the last slide. And then when we add hypertension to the model, we're actually able to progress albuminuria as a marker of kidney injury, and we actually see levels rising towards 15,000 in this model. Obviously, it's really nice to have a lot of albuminuria and a very high blood pressure, but we also have to think about what is physiologically relevant and not. So what we decided to use as a model for for the remainder of the studies that I'm going to present to you, we decided to use this dose of renin, which gave us a blood pressure at around 160, and this level of albuminuria at around 15,000. So just to quickly summarize how we have kind of set up and built this model looking only at albuminuria, well, going from the diabetic kidney mouse with 2 kidneys to the diabetic mice with 1 kidney, and then adding the hypertension, we are really able to really nicely increase albuminuria in this model. But albuminuria is not the only marker of kidney disease. In these mice, we actually have access to the kidney tissue. We can take a biopsy from the kidney and actually study them using histology. So what we're particularly interested in is this glomerulosclerosis, so the expansion of the mesangial matrix that I talked about in the introduction. And what you see here is actually a picture of a healthy mouse kidney. It's a histological section that has been past-stained. And what you can see here is a normal-looking mouse kidney or glomerulus. It's got these open capillary loops, and it's got very little buildup of mesangial matrix, this purple dye. So in the diabetic kidneys, or in the diabetic mice with 1 kidney but normotensive, we see that what we would expect, namely that the glomeruli becomes larger, so we see glomerular hypertrophy. And we also see that although we still have these open capillary loops, so we still have perfusion of the glomeruli, you also see build up of mesangium, mesangial matrix, as this purple or pink stain inside the glomerulus. So this is a really very classic feature of this early stage of diabetic kidney disease. So we are trying to progress the disease. So what does the kidney look like in animals that are also hypertensive on top of the diabetes? Well, now we're talking. Here we actually see glomeruli that are really severely affected by glomerulosclerosis. We see something that is not similar but comparable to the human nodular glomerulosclerosis that we see in the later stages of human disease. And you can appreciate here that we have a lot of matrix built up in the glomerulus, very few open capillaries. That means we have very little perfusion of the glomeruli, and these are really significantly affected by glomerulosclerosis. What you can also see that in the tubular stitchum, we do not have tubular stitchal fibrosis as such, but we do start to see these hallmarks of tubular atrophy, among others. So not only in terms of albuminuria, but also in terms of kidney histopathology, we actually see that we have a model that translates better to the later stages of human disease than previous models. So it's all very nice that we have established this model, and we really hope that it has good translatability. So how do we actually confirm this? How do we actually test that our animals our animal model has a good translatability to human disease? Well, we do this by testing current therapies for diabetic kidney disease. We know how they work in man, so we actually try to test them in mice as well. But I just want to talk just very briefly about the current treatments for diabetic kidney disease in man before I jump into which one we've chosen to test in our model. So I think from a pharmacological standpoint, we've been addressing 3 key features in diabetic kidney disease to not only treat the disease, but basically to prevent the progression of the disease. So first of all, and I think this is the one we're all familiar with, this is trying to control blood glucose in the patients. So we have various therapies to do that, metformin, insulin. These are very familiar and have been used for many years, and then to some of the newer drugs on the market that I talked about before, so the GLP-1 receptor agonists, and also more recently the SGLT2 inhibitors. Last, that we saw a really an excellent progression in the treatment of diabetic kidney disease were when we started introducing treatments that addressed the hemodynamic factors in these patients. So these drugs were originally focused on blood pressure lowering drugs, RAS blockade, such as ACE inhibitors, and also angiotensin receptor blockers. And these are also widely used today. in many patients with diabetic kidney disease and also chronic kidney disease. Recently, we added SGLT2 inhibitor to this list. I think many of us can agree that SGLT2 inhibitors also have hemodynamic effects. I think we're still trying to understand what they really do and how they really protect the kidney in these patients. And that's super interesting research going on still. And then finally, and this is perhaps where we need most research and most development of drugs, is actually addressing inflammation and fibrosis directly, because tubular interstitial fibrosis is really what drives the progression towards end-stage kidney disease and what we really want to avoid. So I think just recently, actually this summer and this fall, we have learned from clinical trials using a mineralocorticoid receptor antagonist, or the MR antagonist, that these are actually also helpful to the patients with diabetic kidney disease. So we have various treatments that have been there for many years and are also coming up. So in order to kind of confirm that our model really has good translatability, we chose two standard of cares. So we chose an ACE inhibitor and also an SGLT2 inhibitor to try to see how they actually perform in the model and whether they have nephroprotective effects in our diabetic hypertensive mice. So in the study, we actually wanted to do a 12-week chronic dosing study. That's a fairly long study in mice that are diabetic, but we did that, and in the study we also included a healthy control. It's always nice to kind of compare your sick mice and your sick mice with treatments to a healthy control. So in the study, again, starting by looking at albuminuria, the albumin to creatinine ratio as a marker of kidney injury. In the healthy mice, again, they have very low levels of albuminuria, around 100. And then looking at the vehicle-treated, so the placebo-treated control mice with diabetes and hypertension, they had albuminuria levels of around 25,000. So that's fairly high in this model. So how did our standard of care work? Well, first of all, the ACE inhibitor, not surprisingly, we are trying to block that bad effect of the renin in the system, and we're actually able to do that. And that lowers the degree of albuminuria in the model. That's what we would expect. And that's, of course, very good. So in terms of the SGLT2 inhibitor, we saw something surprising. We actually saw that when we treated with SGLT2 inhibitor alone, we saw an increase in albuminuria. We are currently looking at why this may have occurred. We have some excellent theories of why this might be happening, but I think we were a bit puzzled about this. But I think what really is encouraging is that when we combine these two treatments, the ACE inhibitor and the SGLT2 inhibitor, we see a really further reduction of albuminuria as a marker of kidney injury. And this is very encouraging. This is the same effects that you see in patients with with diabetic kidney disease. Many of these patients that have been enrolled in the trials where we've tested SGLT2 inhibitor are actually already on an ACE inhibitor or on another RAS blockade. So this is very encouraging and actually confirms the translatability of our model of diabetes. So again, we are lucky that we have the kidneys from these mice, because albuminuria is not the only factor that we want to check out. We also did look at glomerulosclerosis in this model and how that's affected by the standard of care. Glomerulosclerosis is very time consuming to quantify. Normally, when I was a postdoc, I was actually sitting at a microscope for hours and hours and were counting glomeruli and trying to score them using a standardized histopathological score. So that's very, very tedious. And we've actually set up, using AI and machine learning, we've set up an app that can actually do the scoring for us. So for this purpose, we use this standardized preclinical score, where we score all glomeruli from a score from 0 to 4, where 0 is a normal looking glomerulus, and 4 is a glomerulus that are severely affected and actually has a global glomerulosclerosis. So in a kidney section from a mouse, this is what it looks like. So this is a section, a pastine section from a mouse that is diabetic and hypertensive. So one of these mice that have really high albuminuria. And what you can see here is that the app can actually identify all glomeruli. Each of these dots you see is a glomerulus. And once the glomerulus has been identified, the app applies the scoring system. So what you can see here is that we have quite many of these yellow, severely affected global glomerulosclerotic glomeruli in this kidney section, and we have none of these healthy green or near healthy orange glomeruli in this section. So these kidneys are really not doing well. So what happens when we apply our standard of care in this model? So this is an image from a section from the combination treatment with ACE inhibitor and SGLT2 inhibitor. And what you can see here is that all of the yellow glomeruli are gone. So we don't have any of these completely sclerotic glums anymore. They are gone. And what starts to appear are these orange glums, which are the near normal glomeruli. So this is really cool. And we can actually also, we get a lot of data from this. So we get around 150 data points per mouse. So back when I did the counting manually, I would do 20 glums per mouse. I would be really happy. But here we can actually do around 150 per mouse. And that gives us a lot of data that we can then start to look at and use statistics on. So this is an example where I have combined the fraction of the worst glums, so the GS3 and GS4. And what you can see here is that obviously we have basically none of these really severely affected glomeruli in the healthy mice, but in our hypertensive diabetic mice, we have a lot. We have over 50% of the glomeruli are in these two high classes. So these are not doing too well. Then when we apply our standard of care, first of all, the ACE inhibitor, we see a reduction in this fraction. And then furthermore, when we combine the two treatments, we see this further reduction of glomerulosclerosis. So again, supporting that the combination of the ACE inhibitor and the SGLT2 inhibitor also, as it does in man, protect our mouse kidneys from diabetic kidney disease. So I hope I've been able to demonstrate to you that we can combine various modulators to accelerate the disease progression in diabetic mice. And by this actually establish a model with advanced diabetic kidney disease that are able to reproduce the treatment responses that we also see in man. And finally, I also just want to make sure that everyone understands that one model doesn't do the job. Our model does not have features such as the loss of kidney function or GFR that we see in man, and this is of course something that needs to be addressed. In other models where we can study this phenomenon, that could be a 5-6 nephrectomy model, or models of more that replicates kidney fibrosis even further. So just to say that often one model doesn't do the job. You have to combine data from various models to really understand the drug that you are studying. So thank you very much for listening. That was all I had to present today. I'll be happy to take your questions now, and otherwise, if I'm not able to answer that now, you are more than welcome to contact me using my email information that are down here in the corner.
Thank you very much for the presentation, Mette. And please write your questions for Mette in the chat, or as I said before, you're also welcome to ask your questions live to Mette if you prefer that.
I have a question. It's
yes,
Matthias Karlström from Karolinska Institute. So thank you, Mette, for a beautiful presentation and very interesting results. Seems like a very promising model for diabetic kidney disease.
Yeah.
And one of my questions is related to the quite surprising findings on the SGLT2 inhibitor.
Yeah.
So would you be concerned regarding patients with diabetes being treated now with SGLT2 inhibitors unless they are hypertensive and being treated with ACE inhibitors or ARBs at the same time?
Yeah, I think that's a really good question, Matthias, and we were of course surprised about this finding. So I think there are many things that can explain what's going on. I think some of the explanation is that the SGLT2 inhibitors actually can activate the RAS system both systemically and also in the kidney. So that might explain some of it. Certainly, when we combine the ACE inhibitor and the SGLT2 inhibitor, we see that detrimental effect disappearing. So that might be a part of the answer to that. And also another thing is about the PK profile of the drug, and I think that's something that we haven't been focusing too much on in the study that we did. So that might also be a part of the explanation. I do want to say though that looking into the literature, there are, and we are not the only one that see this effect with the monotreatment of SGLT2 inhibitors. I've seen studies both in diabetic models, but also in non-diabetic CKD models, where other groups see the same phenomenon. So there might also be a publication bias to that, and that's of course also to take into consideration. And as you point out in terms of the patients, and I just have to say that I'm not a clinician. I'm only a preclinical scientist, but I think that given that basically all patients that get these SGLT2 inhibitors are on a RAS blockade, that kind of eliminates the problem. I haven't been able to find data where patients have received SGLT2 inhibitor as the only treatment. In the last, I think it was in DACA CKD, I think 97% of the patient population, whether they were diabetic or not, they received a RAS blockade, and then they got the SGLT2 inhibitor on top of that. So no, I in terms of the patients, I'm not super concerned there.
So just to follow up on that, are you planning, or do you have any data when you use the SGLT2 inhibitor, just when you have the DB background combined with a unilateral nephrectomy, in the absence of overexpressing the renin gene?
No, we haven't done that study, but I think there are quite a few publications out there that has. So I think that there's a good data to dig into out in the literature.
Thank you. Great presentation.
Thank you.
And there's a question in the chat from Simon. He asked, what about DB mice and DOCA for diabetic kidney disease?
Yeah, and that's an excellent question, and obviously this is another way of modulating the kidney disease and the progression of kidney disease in models like this, yeah, it's not something that I've looked into myself or that we've been looking into, but it's definitely also a way to go.
Okay, I hope that was a question to your answer, Simon. Any more questions for Mette? And please unmute yourself and ask a question. No, it doesn't seem like there are any more questions.
Well, I can ask, if we have time, I can ask another question. How old are the mice when you are inducing the unilateral nephrectomy? In the model that we have set up, we do the uninephrectomy when the mice are around 8 weeks of age. We do the induction of hypertension using this adeno-associated virus the week before. And then we actually take the animals out to 24 weeks. So that's 16 weeks after the uninephrectomy. Okay, thank you.
Yeah.
So now I'll just thank you for attending, and a huge thank you to you, Mette, for the presentation.